Hi, I'm Dr. Brian Kaufman, a retired family doctor and a CLL patient myself, and the co-founder, executive vice president, and chief medical officer of the nonprofit CLL Society. And I'm going to be bringing you some of the most important papers from the American Society of Hematology's annual meeting, ASH 2024, from San Diego, California. I'm also going to bring you what I think are some very interesting papers that are on topics that you might not think about. And what I'm going to talk about today is a paper whose official title was Bringing Hematological Malignancy Clinical Trials to Patients, Mayo Clinic's LLS Impact Experience. And while this is not CLL specific, it certainly has implications for CLL. The bottom line is, by bringing trials into the community, what Mayo Clinic was able to do was increase access, increase accrual or participation to CLL and other blood cancer patients for rural patients who often don't get the benefits from people who live close to a major academic center. This research was done by an MA, not a physician, out of Mayo Clinic in Rochester, Minnesota, Jamie Johnson, who presented it as one of the prestigious oral presentations at the American Society of Hematology's annual meeting in 2024. In the way of background, many of us recognize that a clinical trial may be the best choice for some chronic lymphocytic leukemia, small lymphocytic lymphoma, or CLL/SL patients. But cost and logistics concerns limit enrollment, especially for those in rural locations far away from an academic center. More than 4 out of 10 of the 20,000 blood cancer patients, including many with CLL, SLL, who were cared for in Mayo Clinic in 2023, live in a rural setting. These patients often face increased challenges related to access, including cost, time and distance for travel, for treatments, and they often have much fewer access to clinical trials. In 2021, our fellow nonprofit, the Leukemia and Lymphoma Society, or LLS, offered grants to improve access by launching its IMPACT. IMPACT stands for Influential Medicine Providing Access to Clinical Trials, IMPACT grant. Mayo was one of the earliest grantees. The grant funds major cancer centers like Mayo and others to partner with local community oncology centers with the goal to increase accrual, increase participation of patients traditionally underrepresented in clinical trials. Those included would be those who are rural, a member of a minority, or economically disadvantaged. In this case, Mayo Clinic, Rochester, Minnesota, was what's called the hub, the academic center, partnering with 4 Mayo Clinic Health System rural oncology centers, including one across state lines and one almost 100 miles away. How did they do it? There was 2 methods used to set up these trials. Trials were offered independently at the hub, at the Mayo Clinic Health Systems, and at the rural oncology practices. Or there was a hybrid method. Here, some intake and some services were done at the hub in Rochester, Minnesota, and some were done in the community. The hybrid model was used to overcome barriers in the rural community that included, but were not limited to, the fact that they had less staff to help support what's needed for a clinical trial. They might not have the adequate equipment for processing the special specimens that are needed. They may have insufficient medication storage and shipping capacity. The rural catchment areas may lack alignment with the hub's trial portfolio, and there's reduced excess capacity of healthcare providers due to the existing problems they have taking care of their patients. the academics often have time carved out to do their research. One important point that I want to emphasize is that what were called champions were selected for each rural site. And in order to make it work, a new position of feasibility specialist was hired to support the efforts facilitating communication and helping overcome any barriers between the rural setting and the academic setting. So, what were the results? 20 clinical trials, including 14 interventional trials, so these would be trials where there was therapy going on, had been activated with 108 patients enrolling. 42 of those were in interventional trials. 5 were in the full activation mode, 13 accruals, and 15 in the hybrid model. So, to remind you, the full activation mode is where the same trial was being done both in the rural setting, completely independent, and in the more urban or academic setting. And the hybrid was where some services were rural and some were at the academic center. Patients averaged 260 miles travel with an estimated cost of $142 per trip to the hub locations. 9 patients traveled over 260 miles with an estimated cost of 160 miles to access. 8 patients in the hybrid trials switched some of their care to their local health care team, resulting in a reduction of an average of 155 miles per visit. Assuming 10 visits for the 108 patients, the total travel saving was over $153,000. Hotel costs saved were also over $16,000 for the 11 patients who were estimated to require overnight stays. The impact on lost days and on care partners needing to help and accompany the patients were not calculated, but there's no doubt that there was significant savings with local treatment, and the convenience and lack of disruption enabled more patients to enroll. So in conclusion, this report points in a direction that a combination of community and academic collaboration, creative approaches, flexibility, and let's be honest, increased spending and staffing, with that, patients in rural settings can save significant costs, and it can help them avoid the inconvenience of travel involved with clinical trials, so they might enjoy the benefits of interventional research locally. It does take considerable money, resources, and a commitment at both the hub and the rural clinics to make it happen, but it sure is worth it. If you want to read the actual ASH abstract, we provide a link to it at the website, Bringing Hematological Malignancy Clinical Trials to Patients, Mayo Clinic LLS Impact Experience. Thanks for your attention.